Contraception Resources from the Centers for Disease Control and Prevention, 2016 United States Selected Practice Recommendations for Contraceptive Use, a webinar from the Division of Reproductive Health at the Centers for Disease Control and Prevention. The findings and conclusions in this report are those of the author and do not necessarily represent the official position of the Centers for Disease Control and Prevention. This presentation will review the United States Selected Practice Recommendations for Contraceptive Use, the intended use and target audience for these guidelines, how to use the U.S. Selected Practice Recommendations, and strategies that you can use to incorporate CDC contraceptive guidelines into everyday practice to improve the quality of family planning care. The U.S. Selected Practice Recommendations for Contraceptive Use, or the U.S. SPR, is an evidence-based source of clinical guidance which answers common contraceptive management questions. The target audience is healthcare providers, and the purpose is to assist them when they counsel patients on contraceptive use and to serve as a source of guidance. The U.S. SPR is arranged by contraceptive method and is subdivided into recommendations such as how to be reasonably certain a woman is not pregnant, when to start contraception, which examinations and tests are medically indicated before starting contraception, and follow-up and management of problems. The guidance is provided both within the text document and summarized in user-friendly charts to guide providers on how to counsel patients for all methods. The U.S. SPR, as the name suggests, consists of selected recommendations. It is not a comprehensive textbook. It does not provide rigid guidelines or step-by-step protocols for contraceptive visits, nor does it provide recommendations for well women care. The U.S. Medical Eligibility Criteria and U.S. SPR are companion documents. Both were adapted from the World Health Organization for the United States context. The Centers for Disease Control and Prevention and the World Health Organization use an automated system to continuously monitor newly published evidence on relevant contraception topics. Topics with new evidence that was inconsistent with current recommendations were selected for guideline updates at a meeting of subject matter experts in 2014. In addition, new topics were also considered. Over the next year, CDC and outside staff conducted systematic reviews of the evidence for these topics. These reviews were presented and discussed at a second meeting of national experts on family planning and reproductive health in 2015, with subject matter experts present for discussion of each medical condition. The Centers for Disease Control and Prevention then finalized recommendations for the 2016 updates. Prior to the development of the World Health Organization and the Centers for Disease Control and Prevention guidelines, most contraceptive guides around the world were based on medical textbooks or on the individual clinical practice of the author. They also generally addressed contraceptive use for healthy women, with the result that in many places around the world, including the United States, women with medical conditions were denied access to contraceptive methods. The Centers for Disease Control and Prevention and World Health Organization wanted to develop guidelines that were based on the best available evidence that would address misconceptions regarding who can safely use contraception and remove unnecessary medical barriers, thereby improving access and quality of care in family planning. CDC's contraception guidelines, including the U.S. SPR and the U.S. Medical Eligibility Criteria for Contraceptive Use, have been endorsed by the American College of Obstetricians and Gynecologists and the North American Society for Pediatric and Adolescent Gynecology. We will now look at the U.S. SPR in more detail and apply the guidance to clinical scenarios. The U.S. SPR contains recommendations regarding the range of contraceptive methods that are listed below. Intrauterine devices, including copper and levonorgestrel IUDs. Progestin-only contraceptives, which include progestin-only pills, depo-medroxyprogesterone acetate injections, and etonogestrel implants. combined hormonal contraceptives, which contain estrogen and a progestin. These include combined pills, patch, and ring. Emergency contraceptive pills, which include levonorgestrel, ulipristal acetate, and combined oral contraceptive pills. Fertility awareness-based methods, such as the standard days methods, and also female and male sterilization. This chart depicts the effectiveness of contraceptive methods. The U.S. MEC and SPR are organized according to contraceptive effectiveness. The most effective methods are listed on the top row. Less than 1 out of 100 women using these methods will become pregnant in 1 year. The methods in this row include reversible methods in yellow, such as the implant and intrauterine devices, as well as permanent methods in blue, such as female and male sterilization. The middle row shows moderately effective methods in which 6 to 12 women out of 100 will become pregnant with 1 year of use. All of these methods are reversible and include injectable contraception, combined hormonal contraception such as the pill, patch, and ring, and the diaphragm, which is a barrier method. The bottom row shows the least effective methods. 18 to 20 women out of 100 using these methods can expect to become pregnant over 1 year. These methods are all reversible and include the male and female condoms, withdrawal, the sponge, fertility awareness-based methods, and spermicide. Please note that condoms should always be used to reduce the risk of sexually transmitted infections. There are 2 new major recommendations in the U.S. SPR in 2016. These include recommendations on the use of medication to ease intrauterine device insertion, and updated guidance on when to start regular contraception after taking ulipristal acetate for emergency contraception. Both of these updates are addressed later in the presentation. To demonstrate how the guidance can be used, we will now go through several clinical scenarios for which the guidance may be useful. For the first scenario, we have a 24-year-old woman who comes to the office desiring contraception. She wants to start pills. How soon can she start taking them? There are several barriers to initiating contraception which increase the time a woman is at risk for unintended pregnancy. Some examples of these barriers are the need to fill a prescription, to wait for next menses to start the method, or to come back for another visit. The term quick start is the start of a contraceptive method when a woman requests it rather than waiting. Quick start may reduce the time a woman is at risk for pregnancy and may reduce barriers to starting a method. Providers may have concerns that a woman may already be pregnant and therefore may not want to start her on contraception right away. A recent systematic review shows that the risk of pregnancy with quick start of combined hormonal contraceptives is low, and that the risk that a woman is already pregnant using the quick start method is also low. Another concern may be that starting combined hormonal contraception on the day of the cycle not consistent with menses may cause irregular bleeding. However, studies from the same systematic review have shown that starting on different days of the cycle does not affect bleeding changes or other side effects. Quick start may increase short-term continuation of both combined oral contraceptives and the patch. However, this difference disappeared over time in studies comparing quick start to other times of initiation. Another concern is risk of fetal exposure to hormonal contraception in early pregnancy. In several studies examining fetal exposure to combined oral contraceptives, there has been no increased risk for adverse outcomes among infants. This chart summarizes the U.S. SPR recommendations for initiating contraception. As you can see, all methods of contraception can be started at any time, as long as the provider is reasonably certain the woman is not pregnant. To ensure that she does not become pregnant once the method is started, she should use appropriate backup for the recommended time period to prevent a new unintended pregnancy. So, returning to our patient and answering this question, the recommendation for pills and for all methods is a woman can start a method anytime if a provider can be reasonably certain she is not pregnant. If it has been more than 5 days since menstrual bleeding started, she will need to abstain from sex or use additional contraception for the next 7 days after starting her combined pills. For the next question, we want to know how we can be reasonably certain she is not pregnant. Some providers may question whether or not they should do a pregnancy test to rule out pregnancy and may also question if a pregnancy test is sufficient. The evidence shows that pregnancy testing does have limitations. Pregnancy detection rates vary depending on the sensitivity of the test and the timing of testing with respect to missed menses, last intercourse, or last pregnancy. False negatives may occur with recent intercourse, while false positives may occur after a recent pregnancy. The U.S. SPR provides highly accurate criteria that a provider can review with a patient to be reasonably certain the patient is not pregnant prior to initiating contraception. If a woman has no signs or symptoms of pregnancy and meets any one of the SPR criteria listed here, a provider can be reasonably certain that she is not pregnant and can quick start contraception. Several studies have been conducted comparing the negative predictive value of this criteria with a pregnancy test. These studies all showed a negative predictive value of 99 to 100%. This means of the 100 women who had a negative result according to a pregnancy checklist, 99 to 100 of them were not pregnant according to a pregnancy test. The recommendation in the U.S. SPR therefore states that if a woman has no signs or symptoms of pregnancy and fulfills one of the criteria, a provider can be reasonably certain that the woman is not pregnant. Routine pregnancy testing for every woman is not necessary. For our next scenario, we want to know, are there other tests to consider or exams that need to be done before providing her with pills? The U.S. SPR also provides recommendations that address examinations and tests needed prior to starting a woman on a method, as unnecessary tests may create barriers to contraceptive initiation. For example, a pelvic exam itself may be a barrier to women getting contraception, especially adolescents, if they are not willing to participate in the exam. Waiting for test results may be another barrier that delays contraceptive use. The U.S. SPR provides recommendations that address exams and tests needed prior to starting a woman on a method. These recommendations are categorized into 3 classes. Class A recommendations are essential and mandatory for a given method. Class B exams and tests contribute substantially to safe and effective use, but implementation may be considered within the public health and/or cervix context. Finally, Class C recommendations do not contribute substantially to safe and effective use of the method. This is an example of a chart of the recommendations for exams and tests prior to initiation of contraception. Down the left side, you can see a summary of potential exams and tests. Across the top are the various contraceptive methods. The only A-level recommendations, meaning essential and mandatory, are blood pressure measurement prior to initiation of combined hormonal contraception and a bimanual exam and cervical inspection prior to initiation of an IUD or diaphragm. These are highlighted in yellow. Most other exams and tests are category C, meaning they do not contribute to safe and effective use of the contraceptive method. Weight or body mass index measurement is not needed to determine medical eligibility for any method of contraception because all methods can be used or generally can be used among obese women. However, Measuring weight and calculating BMI at baseline might be helpful for monitoring any changes and counseling women who might be concerned about weight change perceived to be associated with their contraceptive method. The evidence behind the recommendation for blood pressure management prior to starting combined hormonal contraception is based on 6 case control studies discussed in a systematic review by Dr. Tepper. These studies showed that women who did not have a blood pressure check prior to initiating combined oral contraception had higher odds of acute myocardial infarction and ischemic stroke than women who had their blood pressure checked. There was no increased odds of hemorrhagic stroke. No evidence was identified for other hormonal methods and blood pressure measurement. Pelvic examination is not necessary before initiation of combined hormonal contraceptives because it does not facilitate detection of conditions for which hormonal contraceptives would be unsafe. Women with certain conditions, such as current breast cancer, severe hypertension or vascular disease, heart disease, migraine headaches with aura, and certain liver diseases, as well as women who are at least 35 years old and who smoke 15 or more cigarettes per day, should not use or generally should not use combined hormonal contraceptives. However, none of these conditions are likely to be detected by pelvic examination. A systematic review examined 2 case control studies comparing delayed versus immediate pelvic examination before initiation of oral contraceptives or depomedroxyprogesterone acetate injections. No differences in risk factors for cervical neoplasia, incidence of sexually transmitted diseases, incidence of abnormal Papa-Nicolau smears, or incidence of abnormal wet mounts were found. Thus, the recommendation is that blood pressure measurement should be obtained and evaluated before a woman starts combined hormonal contraceptives, but other tests are not required before initiating this method. In instances in which blood pressure cannot be measured by a provider, blood pressure measured in other settings can be reported by the woman to her provider. Our next scenario addresses the use of emergency contraception. Here we have a 38-year-old obese woman who had unprotected intercourse 4 days ago and is worried about pregnancy. She calls your office and wants to know about her options for emergency contraception. Currently, there are 4 options for emergency contraception in the United States: the copper intrauterine device and 3 types of emergency contraceptive pills, or ECPs. The 3 types of pills include ulipristal acetate, or UPA, levonorgestrel, or LNG, as well as combined estrogen and progestin oral contraceptive pills that are taken in a particular dosing strategy. Since these options are not all the same, how can you help her choose the best option for her? The evidence shows that copper intrauterine devices are highly effective as emergency contraception and can be continued as regular contraception if that is what she desires and she's willing to come in for a visit to have the IUD inserted. For pills, ulipristal acetate and levonorgestrel have similar effectiveness when taken within 3 days of unprotected sex, while ulipristal acetate may be more effective between days 3 and 5 after unprotected sex. Ulipristal acetate may also be more effective than levonorgestrel for women who are obese, according to one study. The combined regimen, known as the USP method, is less effective than the other 2 emergency contraceptive pills and is associated with more frequent side effects, particularly nausea and vomiting. This patient therefore has 4 options for emergency contraception. There are no conditions for which she cannot take emergency contraceptive pills. For emergency intrauterine device use, she needs to meet the eligibility criteria for regular IUD insertion. If she decides to take ulipristal acetate, when can she start regular contraception after taking the emergency contraceptive pills? Resuming regular contraception after emergency contraceptive pills requires consideration of the risk for pregnancy if emergency contraception fails, and the risk of unintended pregnancy if contraception initiation is delayed until the next menstrual cycle. There is no concern with starting or resuming hormonal contraception concurrently with estrogen or progestin ECPs because these methods do not contain an antiprogestin and have not been shown to have negative effects on an early pregnancy. Data on when to start contraception after ulipristal acetate is limited to pharmacodynamic data and expert opinion. One pharmacodynamics study raised concern for decreased effectiveness of ulipristal acetate if hormonal contraception was started the next day. Specifically, the concern was less ovulation suppression. Therefore, after levonorgestrel or combined emergency contraceptive pills, any regular contraceptive method can be started immediately. The woman should abstain from intercourse or use backup for 7 days and take a pregnancy test if she does not have a withdrawal bleed within 3 weeks. For women using ulipristal acetate, they should resume or start hormonal contraception no sooner than 5 days after ulipristal acetate, due to the possible concerns of decreased effectiveness of ulipristal acetate if hormonal contraception is started sooner. This may require a repeat visit depending on her method choice. Non-hormonal contraception can be started immediately. Abstain from intercourse or use backup for 7 days after starting contraception. This patient can therefore resume hormonal contraception 5 days after taking ulipristal acetate. She will need to abstain or use backup contraception for 7 days or until her next menses, whichever comes first. For our last scenario, we have a 19-year-old nulliparous woman who desires a levonorgestrel intrauterine device. She heard that insertion may be painful. Should any pre-medications be administered to ease the IUD insertion or to decrease pain? A recent systematic review, including 10 randomized trials, concluded that misoprostol does not improve ease of insertion, reduce the need for adjunctive insertion measures, or improve insertion success. It also may be associated with increased pain and side effects, particularly gastrointestinal side effects. Routine use of misoprostol is not recommended prior to intrauterine device insertion. Misoprostol may be helpful in select situations, such as women with a recent failed insertion. Paracervical block with lidocaine might reduce pain with intrauterine device insertion. Evidence was insufficient to make recommendations on the routine use of nonsteroidal anti-inflammatory drugs or nitric oxide prior to IUD insertion. Based on this evidence, the U.S. SPR does not recommend the use of adjunctive medications to ease IUD insertion, as no intervention has been shown to ease insertion or reduce patient pain. You can therefore proceed with the IUD placement without pre-medication. In conclusion, the U.S. selected practice recommendations can help providers decrease medical barriers to initiating and using contraception. Most women can start most methods of contraception anytime, including the day of her first visit, as long as the provider is reasonably certain the woman is not pregnant. Few, if any, examinations or tests are needed before starting a contraceptive method. Women should be advised to return at any time to discuss side effects or other problems, if they want to change the method being used, and when it is time to remove or replace the contraceptive method. Otherwise, routine follow-up is not generally required. Many options for emergency contraception are available, including the copper intrauterine device and different formulations of pills, and there are many circumstances for which emergency contraception use should be considered. Regular contraception should be started after emergency contraceptive use. Bleeding problems are a major reason for contraceptive discontinuation. Recommendations on anticipatory counseling before starting a method and management of bleeding problems are provided by the U.S. SPR. The U.S. SPR has a companion document, the U.S. Medical Eligibility Criteria for Contraceptive Use. This document was also updated in 2016. The U.S. Medical Eligibility Criteria, or MEC, is an evidence-based source of clinical guidance for the safe use of contraceptive methods by women and men with various characteristics and medical conditions. It is intended to assist healthcare providers when they counsel women, men, and couples about contraceptive method choice. The U.S. MEC includes over 1,800 recommendations for more than 60 conditions and characteristics, and also includes information on certain drug interactions. I'll now introduce you to some tools that you can use to access the U.S. SPR and MEC in everyday practice. The updated CDC contraception app for Apple and Android smartphones and tablets now includes both the medical eligibility criteria and selected practice recommendations for contraceptive use in a user-friendly format, with easy navigation between the two sets of guidance. It also easily links to other CDC guidance, such as the Sexually Transmitted Disease Treatment Guidelines. This updated app is available for download through our website. Many providers who use smartphones for other clinical references find this to be the easiest way to access the guidelines in everyday practice. Here you can see 3 images. The image on the left shows the first screen on the CDC contraception app. The middle image shows the table of contents when using the U.S. medical eligibility criteria by method. The image on the right shows the table of contents when using the U.S. selected practice recommendations. The following screenshots show an example of how to use the CDC contraception app following the United States selected practice recommendations table of contents. Let's say we're trying to determine how to counsel a patient who had an early detachment of her contraceptive patch. We would first select the SPR from the main menu, which would bring us to the screen on the left. We would then select Combined Hormonal Contraceptives. We can see the various topics for combined hormonal contraceptives on this screen. If we select Missed Doses, we then see the detailed information on how to manage missed doses of combined hormonal contraceptives. There are also links to flow chart figures for each individual method, the pills, patches, or ring. This app includes a similar click-through approach for the medical eligibility criteria for contraceptive use. CDC also has printed and laminated summary tables and charts, which can be ordered or printed from our website. These include color-coded summary charts for the medical eligibility criteria and flow charts with management strategies for the selected practice recommendations, including how to be reasonably certain a woman is not pregnant, when to start contraception, how to manage late or missed combined hormonal contraceptive methods, management of an intrauterine device with pelvic inflammatory disease, and management of bleeding irregularities while using contraception. Posting the colorful flowcharts in a staff work area can help raise awareness and use of the guidelines. The CDC contraception web page for healthcare providers includes an easy click-through version of the medical eligibility criteria and selected practice recommendations for providers who prefer to access these resources online. Finally, we updated several additional provider tools. Many providers find the medical eligibility criteria for contraceptive use pocket wheel pictured here to be useful. It is available for order on our website. Several additional educational tools such as pre-made speaker slides, contraception effectiveness charts, online alerts to receive updates on the guidance, an ebook for the selected practice recommendations, and CME approved activities are available on our website. All of this information, as well as tools and aids for contraceptive guidance, can be found on our website shown below. You can also sign up for email alerts to stay up to date with any new guidance or new tools released from the Centers for Disease Control and Prevention. Thank you for completing this webinar.